we've talked a lot about the fact that G12C is a distinct mutation highly associated with tobacco carcinogenesis, used to be undruggable. So tell us about the drugs. In other words, what are these small molecule inhibitors? How did they come about? And what do we know so far? Because as you said in the introduction, none are actually approved, FDA approved at this point.
So it's been quite a year for these small molecule inhibitors. Again, these drugs were developed to covalently and irreversibly bind to a pocket adjacent to the GTP site, which essentially renders the altered protein in its GDP state, locking GDP in and inactivating the downstream signaling. The first drug that really has made a splash and a name for itself is AMG 510. This drug has been presented several times, most recently, I believe, at ASCO last year, although it may have been an additional presentation. But this was an open label phase 1 study, first in human for adult patients with locally advanced or metastatic KRAS G12C tumors. Some of the key eligibility criteria: you had to have measurable disease, you had to have received prior standard therapy, and most, if not all, these patients had received at least 2 lines of therapy. This wasn't just lung, there were colorectal patients as well. They did not include patients with brain metastases, and that will be interesting to see what the activity of this drug is in the CNS. As in any phase 1 study, the primary endpoint was safety and tolerability. And I think what we've learned about it, just cutting to the chase, is that this drug and the other that we'll talk about are extremely well tolerated. The key secondary endpoints, of course, and the things that we look at included objective response rate and duration of response and PFS. There was a dose escalation study. Cohort 1 was 180, cohort 2 was 360, cohort 3 was 720, and cohort 4 was 960 milligrams. And I only say that because we saw activity with the drug across all of these cohorts. And I think, the first thing to talk about with this drug is the tolerability, because that is the primary endpoint of any phase 1 study. There were no dose-limiting toxicities that were reported from this trial. There were no treatment-related serious or fatal adverse events that were reported. There were no AEs that led to treatment discontinuation. So I think that's important to note. The 960 milligram daily dose was what was identified for the expansion dose, and that was the recommended phase 2 dose. And the efficacy, I think, is probably just as important, if not more. As of at least ASCO 2019, there were a total of, I believe, 34 patients evaluated, of which 23 had lung cancer or non-small cell lung cancer. And the objective response rate, again, these were patients, the majority have received at least 2 lines of therapy, had a response rate of close to 50%, 48%, and a disease control rate of 96%. And I don't think we've ever seen data like this for KRAS mutant lung cancer, and certainly has, I think, landed this drug clearly on the map and moved it on, and will hopefully go through rapid fashion through vetting through the FDA. But importantly, not that many adverse events, maybe some GI toxicity, but clearly a well-tolerated drug with very meaningful activity.